So I'll start with a few basics. So in the science world, this virus is known as SARS-CoV-2, and that's the virus that causes COVID-19. So SARS, you probably heard of from back in the early 2000s, severe acute respiratory distress syndrome. There's been a few different varieties of SARS, and this is a novel variety that, of course, came out about a year ago. It spreads very easily person to person, and because it's novel, meaning it has never been present before, there's little, if any, immunity in humans, and that's why we've had so much trouble with this particular virus. The transmission seems to happen by at least these three ways, that being aerosol, droplet, and fomites, which means objects that are touched and touched by someone else. And not a lot is known about how much transmission is happening by one method versus another. That can be hard to tell, but it's thought that most of it is most likely due to contact or droplet transmission, meaning when you cough or sneeze or even breathe or sing or talk, there's very small little droplets of saliva that can get suspended over a meter or two distance around you, and contact with those tiny droplets when they get breathed in or land on you could end up causing infection in someone around you. Aerosols mean actual tiny bits of the same type of material, but actually suspended in air, and those can transmit for farther than 1 or 2 meters. And there probably is some element of transmission in an aerosol format. Aerosols, a standard mask doesn't protect as well as something like an N95 is what we use to protect against aerosols. But even standard masks protect quite well against contact and droplet transmission. And then fomite transmission we think happens as well. That means, you have COVID-19, you touch a door handle, someone else touches that door handle and then touches their nose. And COVID-19 does live for a certain amount of time on these surfaces. And so that's why hand washing and hand hygiene are very important. So these are the main ways that, that transmission is happening, and mostly the points of entry are the eyes, nose, and mouth. What do we know about transmission? Well, certainly this is sort of the source of a lot of the recommendations you see coming from the CDC and others. We know that the more people you're interacting with and the closer you interact with them and the longer you're interacting with them, probably the higher the risk of having COVID transmission from someone that has it to someone who doesn't. And how much is this happening? Well, here's the dashboard from a few weeks ago. There's been over 75 million confirmed cases worldwide, with the US really leading the way with over 17 million, even though we have a much smaller population than India, for example. Our containment measures have not been very effective here. And deaths, we've seen over 1.5 million deaths worldwide. And again, the US is leading in that, despite having overall very advanced healthcare system with these viral illnesses, and particularly for COVID-19, which causes some unusual presentations of illness. It's something that sometimes cannot be treated well. This is the COVID-19 tracker. This is something you can access online. It's at the CDC website. So this is updated every few weeks, and it basically shows where are the cases being diagnosed in the US and where are the deaths occurring in the US. And those usually line up pretty well, since there's a pretty steady proportion of patients who have COVID-19 to patients who actually die of COVID-19. Seems to be around 2%, and that's pretty steady no matter where you are. So I'm right here in the midst of it in California. Of course, CDC is US centric, so we left Marie and Toronto off the map here. So every country's numbers are different. But certainly the highest population centers are seeing the most cases and the most deaths. So in the US, California, Texas, Illinois, Florida, highly populated states, and they're seeing the highest rates. Just a few basics about COVID-19 and things you'll probably hear about. Incubation period, that's referring to the time between you get exposed to a virus and the time you have symptoms actually come on. And so one of the funny things about COVID-19, I mean, it's true of any virus, but COVID-19 has a little bit longer incubation period than a lot of other viruses. So symptoms may be as many as 2 weeks after exposure, though usually it's more like 2 to 7 days. But this is where you hear all those quarantine for 2 weeks after possible exposure. You'll hear that over and over from different sources. That's because this incubation period can be so long for COVID-19. So if you are around someone that ends up having COVID-19 and it's been a week and you haven't had any symptoms yet, you're not completely out of the woods. It's still possible that you could be in that incubation period and not yet showing symptoms. So this is where the 2-week recommendation comes from. As far as contagiousness of the disease, you are contagious even before you start showing symptoms, but you're most contagious when you're symptomatic. And what symptoms are we seeing? So these symptoms, like I said, can occur 2 to 14 days after exposure. And there's a pretty wide variety of symptoms that COVID can present with. The most common will be cough, shortness of breath, and fever. But there are these other ones: headache, congestion, loss of taste or smell. Actually, one of my best friends just got COVID-19 last week, and he said he knew he had it when he started drinking a glass of red wine and it tasted like water. He said it was really remarkable, the loss of smell and taste that he had. He so far had no other symptoms, and he's a fairly young guy. And this is a fairly common scenario where your symptoms, you could have COVID-19 and have pretty minimal symptoms. Other symptoms you can have: nausea, vomiting, other GI upset type symptoms, and fatigue is very common, muscle and body aches, fever and chills, like I said. This recommendation is sort of targeted to the population at large, but it's actually true for HHT as well. And that is that most people with COVID-19 will have mild symptoms and should recover at home. So just because you have COVID-19 doesn't mean you should be rushing to the hospital or emergency room. The vast majority of these cases will progress similar to another virus or flu, where it's fairly mild. You get better over the course of a week or two, and you don't have any of these major complications arise. But if you do have difficulty breathing, if you have development of shortness of breath, if you start having persistent pain or pressure in the chest, you start having confusion or inability to be aroused or getting bluish in the lips or face, these are reasons that you should be going to the emergency room or hospital to get more acute care. This was a study that was done, a big study out of the UK, and it basically shows what symptoms are people presenting with. I know there's a lot of colors on here, but really the blue ones are the important ones. Look at the height of the blue bar. That is how many patients who present with COVID-19 present with this particular symptom. And you can see the top 3 overall are by far and away cough, fever, and shortness of breath. These are people who were hospitalized. So these patients are mostly presenting with these symptoms, but fatigue, confusion, diarrhea, nausea, vomiting, etc. are all pretty common as well. And you can see down the line what kind of symptoms people have presented with. So how does it differ from the seasonal flu? I think one of the big myths out there is that COVID-19 is just like the flu and we shouldn't be making such a big deal about it. It's not true. This virus is more infectious than the flu. It spreads faster than the flu, and the case fatality rate is quite a bit higher. From what we've seen so far, although it varies a lot with different age and conditions, the case fatality rate of COVID-19 has hovered around 2%, whereas influenza has a case fatality rate of around 0.1%. So we're talking about 10 to 20 times higher mortality of COVID-19 compared to a standard seasonal flu. And on top of that, aside from the mortality, there's a pretty high proportion, around 15 to 20% of COVID-infected individuals that can suffer from more severe symptoms that require medical attention. So these are just the ones I was talking about. Shortness of breath, low oxygen, are not that infrequent when you have a COVID infection. Although still 80% of patients are not having these types of problems, some do. You probably heard these prevention strategies a lot. Identify and isolate infected individuals, quarantine, wash your hands often, maintain social distance, wear a mask or other face cover, practice good respiratory etiquette, disinfect frequent touch surfaces, and avoid crowds and close contact settings, especially indoors. Do masks work? I wanted to devote one slide to this. There's a big study that came out of one of the most respected medical journals called Lancet. This just came out a few months ago, and they basically reviewed over 170 studies that looked at the use of masks with a variety of different SARS type infections, not just COVID-19, but other similar ones that have presented in the past. And when you add all of this data up, they found that the face mask use did result in a large reduction in infection rates, that overall risk. This means basically 15% as many infections were happening if you're wearing a mask compared to people who were not. So suggests that it is not a perfect barrier, but it does definitely make a big difference. And N95 masks were better than standard cotton masks or disposable masks, though both showed a significant benefit. Okay, so I want to get into the last few minutes about what we know about COVID and HHT specifically, but let me start by telling you a little bit about what we know about COVID in other conditions overall, because unfortunately HHT being a rare condition, we actually don't have much data on HHT specifically. And so it's useful to look at some of the other predictors of what could cause poor outcomes in COVID-19. And so this was a giant study of over 20,000 patients out of the UK. and they looked at patients who were hospitalized with COVID-19 and what were the predictors of actually dying after having COVID-19 and being hospitalized for it in these groups. And basically what you look at is this big vertical line here means 1. That means basically no increased risk, no change or difference with this variable compared to the baseline kind of overall population. The farther you get out to the right with these data points, that means the higher the risk is for this particular group. And so you see right away that as age increases, you get these huge increases in the variable in the risk of mortality. So this hazard ratio, this is basically the multiplier of your risk. So if you're under 50, that's basically baseline risk. If you're 50 to 59, your hazard ratio or your increased risk is about 2.5 times the standard risk. If you're 60 to 69 years, it's about 5 times the overall risk for mortality. 70 to 79, 8.5 times. If you're over 80, you have 11 times the risk of death when you develop COVID-19 compared to the general population. So age is a very big predictor, and that's why a lot of the vaccine plans start with vaccinating the oldest patients in the population because of this increased risk. Women seem to be actually have a slightly lower risk compared to men. So it's actually on the left side of this bar. And then here's all the other conditions. So HHT obviously is not here because HHT, we don't have enough patients to make these kind of claims, but we have thousands of patients with chronic cardiac disease, chronic lung disease, chronic kidney disease, diabetes, obesity, neurologic disorders, dementia, cancer, liver disease. What you'll notice about all of these data points is that they're less than 2, meaning they're at less than double the risk of mortality. So there is an increased risk of all of these different conditions, but it isn't a huge like 10 times risk or 100 times risk of mortality. We're talking about a 1.1 times risk, a 1.5 times risk. So, definitely increased risk, but not massively increased risk compared to the general population. So hopefully that graph makes a little bit more sense. This is just showing the age, just kind of underscoring the importance of age in COVID-19 hospitalization. So very few patients under the age of 17 or 18 get hospitalized with COVID-19. But as your age gets older, your hospitalization rates go up and up and up. And if you look at all the deaths that have occurred in COVID-19, the vast, vast majority have occurred in patients that are over 50, though there is still some patients who have died under the age of 40 or even 30. Okay, now we'll get into what we do know about COVID and HHT, and we're going to get into a lot more of what we think about COVID and HHT, but let's go with what we have as far as the science. So in the medical world, this is what we use to learn all the studies that are out there. We use a source called PubMed. It allows you can actually use it as well at home. You can search the PubMed website for whatever you wish. And so I just ran a search this morning for COVID, hereditary hemorrhagic telangiectasia, and we got all of 5 studies. So this is the entire world literature on COVID-19 as it relates to HHT. Since there's only 5, I'll spend a few seconds on each one since there isn't a whole lot to say about these. One was just a case report of a 65-year-old woman with HHT who had low baseline oxygen levels. She had COVID-19, was admitted to the hospital in Brazil, eventually developed respiratory failure and died. Here was a population study from Spain that looked at over 1,100 patients. This actually was a useful study, so I'm going to bring that up on a later slide, so I won't cover it yet. This was just an opinion piece, a letter to the editor about potential risks of COVID-19 and HHT. We'll get into some of those potential risks in just a moment. This next study was an experience from Italy showing some of the mental health effects of COVID-19 and HHT. It showed that loneliness was increased, that mood could be affected, and suggested remote counseling for affected persons. And the last one was an experience also from Italy talking about the nasopharyngeal COVID-19 test versus the oral or saliva COVID-19 test, finding fairly similar accuracy rates and recommending the oral or saliva test whenever possible, obviously because of the nosebleed issue with a nasopharyngeal swab. So we could summarize pretty quickly before we get into the specifics that there's not a lot known about COVID-19 and HHT, or really in any of the rare diseases. There are a few reasons to have some possible concern about COVID-19 and HHT. HHT patients do often have to seek in-person medical care just because of their illness. They may touch their nose more frequently, which could increase transmission. Nasopharyngeal swabs could cause nosebleeds. HHT-related medical conditions although we don't know about HHT itself, we know that some of the conditions that can arise from HHT may negatively influence outcomes, and those could include chronic anemia, heart failure, low oxygen levels from lung AVMs that are untreated, or pulmonary hypertension. I'll let Raj talk about increased clotting risk from COVID-19, but it may have some extra risk in HHT. Some of the treatments we use in HHT do affect clotting in some ways, and so that perhaps that could be additive when you add to the COVID-19. We don't have any data on that yet, but it's a theoretical possibility. Blood thinner treatments, which are recommended in some COVID-19 patients, they may not be tolerated in HHT patients because of bleeding, and then the psychological impact. So very quickly to run through these, as far as the concern, and then try to present a few solutions. Certainly, HHT patients probably seek in-person medical care more often than patients who don't have HHT. As much as possible, try to use video or telephone visits with your physicians. If you have elective tests or procedures that might require you to go into a hospital or clinic, perhaps those could be delayed. Contact your HHT physician about that, but some of those don't have to be done right away. And whenever you have a nosebleed, trying to manage it at home whenever possible. What about frequent touching of the nose? Certainly that can happen with nosebleeds. Always make sure you're practicing good hand hygiene. Use hand sanitizer that has at least 60% alcohol in it, or frequent hand washing before you're touching the nose with a nosebleed. The nasopharyngeal swab testing, as I mentioned, there was a study looking specifically at this. Testing may be necessary sometimes, but do it when advised by your physician, and those guidelines are changing, it seems like, week to week. But whenever possible, oral swab or saliva testing is probably the preferable way in HHT patients if it's available. It's not always available. The good thing is that even though that's not always available, there are better and better nasal swab testing. So it used to be you had to take this stick and basically jam it all the way back in your nasal cavity, which obviously would be quite traumatic and could trigger a nosebleed very easily. The more recent ones, you don't have to put the swab back as far. So this is something where saliva testing will increase in availability over time, but may not be out there for everyone now. We do not have it routinely at UCLA, for example. What about HHT-related medical conditions? Please go to the Cure HHT website. I actually pulled this directly off of their page. They have some discussion about COVID-19 and HHT, and based on the opinions of the HHT physicians out there, we do think that there are some comorbidities or associated conditions that would be considered higher risk. That would include patients with heart failure, pulmonary arterial hypertension, untreated pulmonary AVM, so they have chronic low blood oxygen levels, and patients who are frequently accessing the healthcare system. What about increased clotting risk with COVID-19? I'll let Raj cover this, but I think that if you have big pulmonary AVMs and you're waiting on treatment, I think it's probably best to go ahead and get those treated. I've been continuing to treat pulmonary AVMs of significant size even during the pandemic because I'm a little worried about the risk of patients having untreated pulmonary AVMs. I'd rather get those treated whenever possible. But in general, if you have HHT and you go to the hospital or getting some sort of treatment that's related to COVID-19, you should be able to receive standard of care therapies in almost all cases. So we don't want HHT patients really treated differently. You are eligible for the same treatments as the general population. Clotting risk, I'll let Raj discuss as well, but we may sometimes change treatments a bit if you're actually diagnosed with COVID-19. Psychological impact, I think this is affecting all of us, including physicians, but trying to keep in mind that distance doesn't always mean isolation. So trying to maintain close contact with your family and friends through Zoom or FaceTime or phone calls. And then if you are having trouble or feeling depressed mood or feeling even PTSD, there are web-mediated counseling services available, so ask your physician about those. This study was actually the one I mentioned. It was one of the more useful studies that's out in the literature, and it's basically about, is COVID-19 and HHT any worse than COVID-19 in the general population? And so they did a survey in Spain of 22 hospitals, and they covered about 1,200 patients. Only one patient with HHT was admitted with a COVID-19 pneumonia. She recovered well and was discharged. And so they were actually kind of struck by how few HHT patients were diagnosed with COVID-19. And they considered the possibility that maybe HHT patients are so worried that they're self-isolating more and not coming in contact with the virus, or perhaps there's some other effect that we don't yet understand. We actually just did this very unofficially amongst the site directors at a variety of centers of excellence for HHT across North America and Europe. We basically sent out a questionnaire to all the site directors asking, have you had patients with HHT and COVID-19 and how has it gone? And what we found was that we had respondents, when you add it all up, about 40 total cases from these 14 centers for COVID-19 and HHT patients. That's out of thousands of patients. So actually that case positivity rate is pretty low. 40 out of, even if it was just 1,000, would be about 4%, which is just what we showed in the poll earlier. So that is all kind of lining up. Even more importantly, most of these cases seem to be mild. There were a few complications that may or may not have been related to COVID-19. There was an MI and a small stroke that were reported. There were 2 COVID-19 related deaths in HHT patients. This is again out of several thousand. They were both in patients that had other medical conditions that could have contributed to the illness. And what about patients with known pulmonary AVMs? Whether treated or untreated, the course did not seem very different to non-PAVM patients. There were a few reports of patients that had low baseline blood oxygen that seemed to be a little bit more affected, having their oxygenation worsening. But overall, those patients did well and did recover. No incidences of abnormal clotting that we've reported at our sites. And so this observational data so far is not showing an increased risk of COVID-19 in HHT patients. So sorry to have taken so long with this, but just to conclude, we do know that COVID-19 is highly infective. We know it's easily spread, and we know that it's a very different virus from what we've seen before. It has a variety of clinical courses, most commonly fever, cough, shortness of breath, loss of smell and taste. Most cases, about 80%, are mild, 15 to 20% require hospitalization, about 2% of cases are fatal. But as we saw in those graphs, age makes a huge difference. So way less than 2% are fatal in young patients, and quite a bit more than 2% are fatal in the elderly. Be sure to wear a mask, socially distance. Indoor gatherings have been shown to be 10 to 20 times more dangerous than being outdoors, and wash hands, have good hand hygiene. But the positive news is that HHT patients don't seem to be overall being affected worse than the general population, although we should consider those certain subgroups to be at higher risk. So my email is here. I think I wanted to open up now to our other speakers. This was kind of just the overall baseline information we know, and then we'll allow our other speakers to talk and then get into the questions.
Great, thank you so much, Dr. McWilliams. And so now while Dr. Kasturi loads up his presentation, we'll do another poll. So if you could just take a few seconds to answer the question, have you visited the COVID page on the Cure HHT website? We have an active group. Thank you so much for all your responses. They're still trickling in. We'll give it another second or two. And so, Dr. Kasturi, I will let you respond to the poll results here before your presentation.
Thank you very much. Thanks for the opportunity to participate in this event. And it was a great talk by Dr. McWilliams, and he's covered a lot of what we all wanted to say. I'm just going to add a little bit specifically to hematological aspects, clotting, bleeding, anemia management. And looking at the results of the poll, it looks like a good number. Almost 50% of the audience actually have looked at it. And for those of you who haven't, I would strongly encourage you to go look at it. It is updated as new information becomes available, so it'll be a good resource for all of you. And it's very easy to access as well. Okay, so this is just with respect to clotting and bleeding problems and anemia management with regards to COVID. There we go. So let's tackle clotting and bleeding concerns first. The question that comes up is, does COVID-19 infection increase risk for clotting? Now, this is not just an HHT population, but also in the general population. And we've had a flurry of activity on this early on in the first few months. The reports were quite alarming of very high risk for clotting, but then as we started to get more and more information over the last year, And keep in mind that the vast majority of the information we get is from patients who've been admitted to hospitals with COVID. So we don't know as much with regards to how people are doing when they get COVID, but it's a mild, mild symptoms managed primarily at home with quarantine and social isolation. This is biased towards hospitalized patients. So early estimates said in the critically ill patients admitted to the ICU on a ventilator, requiring other support, the risk for, or the reports of thrombosis so clotting problems was 20 to 30%, some reports even higher. But when they then, as more information started coming in, when they looked at people who were admitted to the hospital, but not critically ill, not in the ICU, the incidence of clotting problems was much lower, somewhere around 7%, so less than 10%. And it's also interesting that a lot of these clots happened primarily in the lungs in these patients, not the classic blood clot in the leg, what we call DVT, that then breaks off and gets trapped in the lungs, what we call PE or pulmonary embolism. This was all primarily noted in the lungs, oftentimes on CT scans for follow-up of the COVID, not so much looking for blood clots. And so there may be something unique to COVID that causes what we call maybe primary pulmonary thrombosis, meaning the clot happened in the lungs and not so much happened in the legs and then traveled to the lungs, which is what we would typically see with a lot of other diseases. And what is driving clotting problems in COVID is quite complex, but a big part of it is related to inflammation. So the infection with COVID does result in a very intense response that is primarily inflammatory immune response. And there is a relationship between inflammation and clotting, and a good amount of why people with COVID develop clotting is probably related to that. So in answer to this question, does COVID-19 infection increase risk for clotting? I would say yes, it does, but not as much as we feared initially. And context matters too. The biggest risk is in critically ill ICU patients. Okay, let's talk about bleeding. Does it increase risk for bleeding? In general, taking all COVID patients, bleeding is uncommon in patients with COVID infections. Of course, the exception again is critically ill patients who may have an increased risk for bleeding. That has been reported. One study reported almost a 5% risk of bleeding, but again in ICU patients. Another thing that can happen in with COVID infection is patients can develop low platelet counts, and platelets are what help us make a blood clot and stop bleeding. So low platelet counts do increase a person's risk for bleeding. And so that can also be a factor in why COVID infection can cause bleeding. So overall, the concern is primarily, like I said, in critically ill patients and those who may have developed low platelet counts. On the whole, in patients who are at home, I don't think that they should be worried about a significantly increased bleeding risk. There are some approaches that we have incorporated to decrease clotting complications. All hospitalized patients are being placed on preventive dose blood thinners to prevent development of clots. Now, the benefits of preventive dose blood thinners in non-hospitalized individuals who are diagnosed with COVID but managed in the outpatient setting, or those who are hospitalized and managed in-house, or for patients who are discharged from the hospital after being admitted for COVID, is now being looked at in a group of trials called the ACTIV-4 clinical trials. So each of these three settings, they're exploring whether there is any benefit to doing some form of blood thinners to prevent clotting. So more to come on that. So implications to the HHT community, and Justin touched on this a little bit. I think the implications are primarily in regards to medications that a number of our HHT patients are on to decrease bleeding or other HHT-related complications, nosebleed, GI bleeds, liver AVMs related complications. And these could be estrogens, tamoxifen, antifibrinolytics, so tranexamic acid or Lystida, aminocaproic acid or Amicor. Good number of patients are on bevacizumab, Avastin, and also some on pomalidomide. There's a clinical trial that's ongoing now, the PATH HHT trial looking at this, and pazopanib. So These medications are associated with some increased risk for developing blood clots. But again, in the outpatient setting, if patients are otherwise doing well, that risk is not that high, or they won't be on these medications to begin with. Now, the next question that comes up is, should I stop any of these HHT-related medications? And my answer in general would be no. Don't stop it. The last thing we want is to stop these medications, develop worse bleeding, and end up in the emergency room, which is going to increase risk for COVID exposure anyway. I would say discuss with your doctors that you are on these medications if they don't know already. The exception may be, as Justin already brought up, if a patient is already admitted to the hospital with a COVID infection, then these medications may be temporarily held to decrease risk for clotting for a few weeks until recovery, at which point we could resume them. Just one slide about anemia management, and this comes up. A lot of my patients have asked me as well, should I delay my infusions, whether it's an iron infusion or an Avastin infusion or a blood transfusion, because of fear over being exposed to COVID? And again, my answer to this is no. We recommend, and this is what I have been doing, continuing any planned treatment as usual, whether it's an iron infusion or Avastin infusions. And the rationale for this is, while this will increase your encounter, your interaction with the healthcare system, the infusion clinics are all following very strict guidelines. Everybody is using PPEs to prevent exposure, and a planned controlled exposure to the healthcare system briefly to get an infusion is much safer than the converse, which would be a bad bleed at home, calling 911 and having EMTs come home, which is not so much of a controlled setting. So that's what I had to say, and we'll talk more about all of these in the Q&A side. Thank you.
Great, thank you so much, Raj. And so our final presentation today will be with Dr. Marie Faughnan from the University of Toronto, St. Michael's Hospital. And while she's bringing up her screen, we'll do our last poll for today. Do you plan to get the COVID-19 vaccine if and when it is offered to you? Okay. So Dr. Faughnan, here are our results.
Wow, those are amazing results. Those are probably the best uptake results I've ever seen for a vaccine. So so maybe we could just skip my part of the presentation. Everyone's already in the loop. No, I'm happy to talk through this, but that's encouraging that this is upfront the way people are feeling about the COVID-19 vaccine, because that's certainly encouraging that as a society, that we're going to be able to make progress in the fight against COVID if we have that sort of uptake of the vaccine. So it's a pleasure to be here today to talk to you about COVID vaccines and the implications for people with HHT. I'm going to be really brief, but I wanted to first of all, just going to make sure. Okay, first of all, mention that I'm going to address briefly a few of the common myths about the COVID vaccine. But before I do that, I'm going to talk to you a little bit about how the current vaccines were made, just to try and give you a bit of insights into what we can expect from the vaccines, and what things we maybe don't need to worry about that have been fears that have been much discussed in the media and in the general population. So these are a couple of slides just to give you a bit of background about COVID and the vaccine development. So the important thing on this slide is just what COVID looks like. It's covered. This is a COVID virus and it's covered with a protein called the spike protein, which you've probably heard about. And the spike protein has really become the key to virus development, to vaccine development, and it's because it's the key to our immune response right now against the COVID virus. So as we've as the sort of race began to develop COVID vaccines, people were looking at what would be the optimal way to interfere with COVID infecting human cells. And the bottom line is we want to get in between the COVID virus and the human cell and avoid it infecting the human cell. So you can see here, this gray area down here is a human cell, and this is a COVID virus. And you can see that normally the COVID virus spike protein will attach itself to this receptor called the ACE2 host receptor on the human cell. And that will help, and that's how the COVID virus gets into the human cell and infects it. However, if we have antibodies or anti-spike protein antibodies, then these can come and block this interaction. So that's really the key to vaccines in COVID, in the COVID pandemic. And so the two ways that we really think that we can most effectively block COVID infection is, first of all, if we can coat the virus with antibodies to the spike proteins. And the second way that our immune system can naturally fight COVID, and also that vaccines can help us fight COVID, is by stimulating killer cells to come and attach to an infected COVID cell and destroy it. Okay, so we have antibodies, and we also have cells that can be activated in our immune system to fight off COVID infection. So most people have heard a lot about the most recent technology in vaccine development, because these have been sort of the first to trial and first to market and first approved of the COVID vaccines. These are these messenger RNA vaccines, and I'm just going to spend a couple of minutes explaining this. And don't worry about all the detail on this slide. I'm just sort of using it as a platform to explain the concept. So I've told you that what we want to do is find a way to get the human body to create or to make antibodies to the spike protein, okay? And the way that human cells make proteins is from DNA coding into what's called messenger RNA, and then the messenger RNA translates or codes for a protein. Okay, so the whole idea behind the COVID vaccine development is the idea that you want to trick human cells into making spike protein and then showing it to the body's immune system so that the body makes antibodies to the spike protein. Okay, so the messenger RNA vaccines, the trick happens at the level of the messenger RNA step of the process. Whereas in the more traditional type vaccines, like the AstraZeneca vaccine, the trick happens at the DNA level, okay? So in the messenger RNA or the Moderna and Pfizer vaccines, what the scientists have actually done is develop a particle that is injectable that can go and insert messenger RNA into a human cell, and then that human cell will make, from the messenger RNA, will make spike protein and show it on its surface, and then the human immune system can then, or that person's immune system can then react and make antibodies. Okay, so this does not go into the nucleus and does not change someone's DNA. It just goes into what's called the cytosol, or the fluid in a human cell, and tricks it into making these spike proteins. The more traditional type of vaccine, which is now coming to market as the AstraZeneca vaccine and others, is actually, it's similar, but the trick happens at the DNA level. So what happens is that we inject a benign form of virus that delivers a little bit of COVID spike DNA material into the nucleus, and then that DNA material uses the local machinery available in the human cell to make RNA and then spike protein, show that protein, and then the immune system responds by making antibodies. So it ends up kind of with the same sort of response, but the trick happens at a different level. So a quick word about some of these new vaccines, the Pfizer and Moderna vaccines, the messenger RNA ones, because people have been quite worried about the side effects of these vaccines. And then I'll talk a bit about the myths, and then we'll move on to our questions. So first of all, this is a slide from our Toronto Public Health info sheet where that's being provided to people getting the Pfizer vaccine. So we've mostly been administering the Pfizer vaccines in Canada. And if you look quickly at this table of side effects, it's pretty much like any other vaccine. Okay, most of the most common side effects are having some soreness at the site, having a headache, or feeling sort of achy. Some people even have fever or chills, but it's not from an infection. It's from the immune system generating that reaction that we want it to fight off, to create the antibodies in the cells so that we'd eventually be able to fight off a COVID infection. The allergic reactions, though much talked about in the media, are actually very rare, and we can come back to those in the question and answer period. So just to come back to finish now with the myths, just some really key points that I wanted us to talk through. So a lot of people are wondering if maybe these vaccines will be useless because maybe their effect will wear off over a number of months. And that might be true. We actually don't know what the long-term effectiveness will be, but that's not to say that the vaccine will be useless. It just means that we're going to have to be wise about when we need to revaccinate, sort of like we are with influenza, where we need an annual vaccination. The second is that the COVID vaccine will alter my DNA. Not so. None of these technologies lead to any alteration or any interference with the host cell, the person's cell that's being vaccinated with their DNA. Third myth is the vaccine will cause COVID infection. No, none of the current vaccines, the ones I've talked about or the other ones that are up for approval, contain live virus. So you cannot get COVID from a vaccine. Fourth is virus mutants will make the vaccine useless. Well, this is a concern. To date, it seems that most of the mutants that have been identified have not had significant changes in the spike protein. So we don't think that they've rendered the vaccine useless, but it may be at some point that some of the vaccines will have to be re-engineered to be able to be useful for new variants. Fifth one, if I've reacted to the flu vaccine, then I'll react to the COVID vaccine and I shouldn't get it. Not so, they're quite different ingredients. Number 6, there's no point in getting the COVID vaccine if I've had COVID. Not true. There's every reason to think that getting the COVID vaccine, even after someone's recovered from COVID infection, may be very helpful in terms of extending or boosting the immunity. And then finally, and I think this is super relevant to HHT, there's been this, one of the safety recommendations around the COVID vaccine is you need to talk to your doctor about whether you should get it or not if you have a bleeding disorder. And unfortunately, this has worried a lot of people with HHT, but this is really not relevant to HHT. It's about, if someone's on a blood thinner or they have a bleeding disorder, when they get their shot in the shoulder, maybe they'll get a bigger bruise, and that everyone should be aware that they may be at risk of bleeding from the injection. So this has nothing to do with HHT, and this concern does not apply to people with HHT. So I just want to close by saying that, though each person needs to, each person is individual and should be consulting their doctor and should be following local public health advice, HHT itself is not a reason to avoid getting vaccinated for COVID. COVID vaccination should be as safe for people with HHT as the general population, and it should be as effective as well. And as the others have said, some people with HHT may be at higher risk of getting really sick from or dying from COVID, though overall the evidence seems to be that people with HHT are having pretty mild disease, but the benefits would outweigh the risks of vaccination in people with HHT, like the general population. Thank you very much.
Well, I want to thank all of our panelists, Dr. McWilliams, Dr. Casturi, Dr. Faughnan. Your insight and guidance, resources is just been amazing, especially in this incredible, unique time in our history. And we really appreciate all that you're doing for the Cure HHT as well as the community around the world. So it is now time for us to answer questions. We did have over 400 people from 14 different countries register for this webinar, and we have about 200 on the call today. So we're not going to be able to answer every individual question, but we'll be doing our best to answer as many as time allows. And I believe that our speakers are willing to stay a little longer. So we're going to probably go to about 1:15 just so we can try and get a few more questions in. Just remember to keep your questions general in nature so that it benefits everyone. And I would also ask that you put it into the Q&A box at the bottom of your screen versus the chat box so that we can track that a little better. So now I would like to introduce Cure HHT Executive Director, Mary Ann Clancy, who will be moderating today's COVID panel Q&A discussion. So Mary Ann, if you could unmute yourself, we're ready to begin.
Hello, everyone. I'd say good morning, good evening, good afternoon, since we have so many people around the world. And I want to welcome you all, and I especially want to thank all three of our HHT physicians for really helping to provide such important guidance. So many of you sent questions in, so we're going to be addressing those as well as those that are coming in. So we will also have some posted on our website. So I encourage you and your family members to check our website regularly for COVID updates. We have a lot to get to, so let's get started. So the first question is, if I contract COVID-19, do I need to make my HHT physicians aware?
I'd be happy to answer that one, Mary Ann. I would say absolutely yes. I think that not only is it important that people let their HHT physicians know in case they have, their HHT physician has specific advice for them during the course of their sickness, but also really helps us understand, what's happening, how people with HHT are responding to COVID infection.
Great, thank you very much. Another important question is, when is it safe for me to return to my center for treatment, whether it be for lung or brain treatment, scans, and then are the centers up and running? Are they seeing patients? What would your recommendation be?
I could take that one. So our centers are open. Of course, this is going to differ from center to center and from patient to patient, but definitely be in touch with your HHT physician to see what options are out there. At our institution, we have remote visits. So I'm seeing a lot of my HHT patients by video visits where they don't have to come in person. As far as treatments, most of those treatments should probably continue through the COVID pandemic, but if they're truly elective procedures, like perhaps you have mild nosebleeds and you go once a year and get a cauterization, probably best to just wait on that. Whereas things like large lung AVMs that require treatment, I would not wait on things like that. So these are going to be quite different for different individuals and different centers. So please contact your HHT physician with specific questions. But I would say in general, continue to get infusions to prevent anemia. Like Raj said, get your lung AVMs treated if they're significant. Things like brain AVMs, it depends a little from case to case because some brain AVMs, in fact, a large proportion of brain AVMs are quite low risk of rupture in the short term. And so those can often wait for treatment, but in some cases they may need to be treated more promptly. For your nosebleed management, I think as much as possible, do nosebleed management at home rather than going in for nosebleed related procedures. But of course, that depends on the severity. So I think in general, we could say to continue the urgent care and the most important care for your HHT, whereas more elective procedures and less urgent things could be put off until this pandemic has started to wane.
Thank you. Am I considered at higher risk if I have HHT and PH, and then HHT and asthma?
Actually, you could take that one too. So, oh, actually, I should let Marie take that one. She's a pulmonologist. I'll let her to answer this one.
No, please go ahead, Justin.
So there is some data in asthma and pulmonary hypertension. Unfortunately, we don't know a lot specifically about because it isn't a super common illness, but it does. We expect that severity of HHT or the outcomes of HHT could be worse with pulmonary hypertension or any other chronic lung disease. And asthma, in mild asthma, probably not much difference has been seen so far, but in moderate to severe asthma, CDC has just released some additional guidelines stating that there probably is some increased risk in patients with moderate to severe asthma because they tend to have more, their lungs tend to be more sensitive to these types of problems. And so you might have more of an immune response that could be potentially harmful in the lungs. So asthma could be a problem if you have more severe asthma. Lung AVMs, when treated, we don't think that you have any increased risk if you have treated lung AVMs. There should be no worsened susceptibility to COVID. There should be no worse outcome from COVID if you have treated lung AVMs. But if you have large untreated lung AVMs, you could have low baseline oxygen levels, and those could contribute to worse outcomes from COVID-19. And also, as Raj said, there may be some increased clotting risk with COVID-19. And so if you had a big lung AVM and then you had a COVID-19 and developed a clot, that clot might be able to pass through the lung AVM and cause harm like a stroke. So that's why I said in general, if you have large lung AVMs or significant lung AVMs, those should be treated even during the pandemic.
I completely agree with everything you said, Justin. Thank you.
Another interesting question, since liver AVMs are pretty prevalent in patients with HHT, is this considered liver disease? Is there an increased risk? And should we have a cardiac consult?
I'll take that one. Yes, liver AVMs are quite common in HHT, particularly as people with HHT get older. We know that the vast majority of liver AVMs are asymptomatic, and having an asymptomatic, incidentally identified or screening identified liver AVM, I don't think renders a patient at increased risk for getting COVID or for complications from COVID, right? The subset, the minority of patients who have symptomatic liver AVMs with high output heart failure may be at increased risk, as our communication from last month on the COVID webpage of Cure HHT clearly says that may be considered an increased risk, but not otherwise.
Thank you. Regarding testing options, if we get the nasal swab and it does create nosebleeds, does the bleeding negate any of the results from the testing? And would the saliva test be better?
I think in general, when available, I would prefer giving the saliva test for any of my HHT patients, just because I think the likelihood of a nosebleed is quite high when you're getting one of these nasopharyngeal swabs or even an anterior nasal swab. So certainly if you have it available, saliva testing is great. We don't have any evidence showing that testing is going to be less effective in HHT patients if you do get a nasal swab, even if there is some bleeding. Those nasal swab sensitivities are pretty good, and we haven't seen any data suggesting it's any worse in HHT.
So this is a question about someone who did contract COVID-19 in March and has multiple PAVMs and headaches and loss of breath. And the question is could that be COVID, HHT, or a combination of both in terms of complexity?
I can try and answer that. So, there are a number of people who develop COVID infection, like outside of HHT, who can have quite a prolonged course. It's a small percentage of people, but it is something that we see. And the prolonged course tends to be with shortness of breath and cough. And those people often have changes on in their lungs that we can see on the CAT scan, and that can take several months to resolve. It's sort of like an inflammatory process that's slow to resolve. So if, I think for someone who had symptoms like that, I would definitely suggest that they get assessed. Either, they should talk to their HHT center who could, and they can probably handle the assessment or guide the assessment through a lung specialist for those ongoing symptoms. Because I think that's more about the COVID infection than about this, specifically the HHT.
Right. So along those lines, in terms of impact on the respiratory system and the lungs, do we know if COVID will have a permanent impact on the respiratory symptoms, and will the lungs be damaged permanently? Has that been addressed?
The evidence so far is that there's a small percentage of people that may that will likely have some long-term scarring, but that most people's lung function seems to be recovering normally, but the amount of time that it takes to recover is quite variable.
Okay. I think this would be for you, Dr. Kasturi. I tested positive for COVID-19 in November and take vitamin K daily, as it really helps to cut down on my nosebleeds. I had COVID-19 2 weeks ago and stopped taking the vitamin K because of the risk of excess clotting. Would you and any of the other speakers comment on the vitamin K and COVID aspect?
Sure. Specific to COVID, I'm not sure that there's any data on vitamin K, none that I've come across. But in general, people take vitamin K to make sure that they don't develop a bleeding tendency, because vitamin K is a critical part of how normal clotting works. But the converse has not been shown, meaning taking vitamin K when your clotting system is normal does not increase your risk for clotting complications. Does that make sense? Not having vitamin K would increase your risk for bleeding, but taking vitamin K when you don't need it, or taking excessive vitamin K, is not going to push you over the other end. So vitamin K supplementation has been shown to be safe. It's very popular in Japan. A lot of Japanese take it routinely. And there isn't an increased risk for clotting from that side. Now, with respect to COVID and the recent COVID infection and resuming vitamin K supplementation, if you recovered, you're back at home, I would say it would be good to resume vitamin K, definitely after 4 weeks from the time you're being discharged from the hospital or from diagnosis. That would be when I would resume the vitamin K, and I'm not concerned that that's going to hurt you.
Thank you. On the same hematologic question, does COVID-19 affect iron or hemoglobin levels?
COVID-19 does not directly affect your iron levels in any way. It's not going to make you more iron deficient. Any critical illness or any significant illness can temporarily cause an anemia. It's called anemia of inflammation or anemia of chronic disease. It's just when the body is dealing with a lot of stress, it secretes certain proteins that can actually decrease how well our bone marrow can make blood cells. And that's well described. So it would not be uncommon for people who have had a COVID infection, particularly those who have had it bad enough to be admitted to the hospital, to develop an anemia because of it, but they should recover from it as they recover from the COVID, but no direct impacts on iron.
Is there an official position on blood thinners and COVID-19?
So in general, outside of the HHT population, there are society guidelines. The International Society for Thrombosis and Hemostasis has come out saying they lean towards recommending prophylactic blood thinners for patients who've been admitted to the hospital with COVID. So that's as good as we have right now. But outside of that, there aren't any society guidelines.
So we've had a few people who said that after they got the first dose of the vaccine, their nosebleeds increased. Should they wait beyond the 21 days for the second dose?
I can take that too. So I think the immediate response to the vaccine, which is what causes us to feel achy or fatigued or anything. It's essentially revving up your immune system to make the antibody. And as part of that process, if you've got some degree of inflammation in the body, that might cause you to maybe have more nosebleeds for a couple of days. I don't think that the longer you wait for the second dose, that would necessarily impact whether you're going to have nosebleeds or not with the second dose. Therefore, I would say if it was only a couple of days of excessive bleeding, I think there is a plausible reason for why that's happening. I expect that the same would happen probably with the subsequent dose too, but that shouldn't be a reason not to get it or to delay it. I don't know if Justin or Marie, you think differently. That's a good question.
I completely agree, Raj. It would be best to not delay.
And that would be the same if you've had a bad reaction to the first dose, not delay getting the second.
Well, the only thing is, the type of like having worse nosebleeds for a few days after is different than a vaccine specific reaction. So if somebody has a reaction that might be an allergic reaction to the vaccine, they should not get the second dose. So anyone who has a reaction to the vaccine, other than the usual things that we talked about, sore arm, achy, for a couple of days, anyone who has other reactions to the vaccine or uncertain whether they do, they should consult their doctor before they get the second dose.
Thank you. Yes, it's totally different. Do we know what the position is for children with HHT receiving the vaccine? Is it going to be recommended for children, and do we know when it will be available?
I can only speak from California. I think every state is different and other countries are different as well. Children will probably be the last to receive the vaccine. Thus far, it has not been tested very well in children. The Pfizer vaccine, the minimum age was 16. For the Moderna vaccine, minimum age was 18. There are studies ongoing now with Moderna in younger adolescents. So we will have more data coming out about the effectiveness of the vaccine in kids. For all we know, everything that we know so far, it is safe for kids and probably effective, but those data are not yet out because the big studies focused on adults. We do know, based on some of the data I showed, that kids seem to be much less affected by COVID. They have much better outcomes than older adults do.
A question on Avastin. If I am taking Avastin for management of HHT, should I be letting my PCP know that locally?
Yes, I think all your providers should know if you're on any medication, but certainly Avastin, yes.
Okay. And there are several questions on when can I get the vaccine? Can we be, after healthcare providers, can HHT patients be next in line? How do we sign up? Questions like that.
These are really, those are really important questions, and the answer to those questions are really going to come to people locally. So each state, country is going to be putting out their guidelines for prioritization of how they're rolling out the vaccine. And so it will be different whether you're in Canada or whether you're in California or whether you're in Europe. That prioritization will differ from place to place and will be implemented locally. However, I think that one thing that I think HHT patients can do is talk to their HHT center about whether they're considered to be someone who has, or consult the Cure HHT info about whether their HHT is enough or of a type that they should be considered a high-risk patient. So we talked a little bit about this already. People with symptomatic liver vascular malformations and heart failure, well, those people would fall into a higher risk category than someone who has HHT and mild nosebleeds and no organ involvement, who would be considered more like the general population. So I think that it is important for people to figure out where they stand in that. Am I a high risk person or a regular risk person? But then the actual access to the vaccine and the prioritization will be based on local public health rollout and prioritization.
Thank you. That's really helpful, I think, for a lot of people. We have a few more minutes, just a few more questions. If I have HHT and my other family members do not, would it be more effective for them to get the vaccine to help me?
Everybody should get it. I think is the best answer, honestly.
Right. And then we had another question. I think it was referred to in the talk, but we'll ask it again. Should we take the vaccine along with taking Avastin, or should we stop for a few weeks before the vaccine?
Yeah, I just saw that question too. So I think it's okay to take Avastin and be vaccinated. I can't imagine why being on Avastin would either interfere with the efficacy of the vaccine or increase vaccine-related complications. And I certainly, if somebody's HHT-related symptoms are severe enough for them to require Avastin, I need a really good reason to stop it. And the vaccine is not good enough of a reason. I think it will be safe, and I would encourage not stopping the Avastin and going ahead and getting a vaccine.
Raj, I agree. And I think also to your point, if someone is sick enough from their HHT that I'm prescribing Avastin, then it's also someone that I probably want to make sure they get the vaccine. Correct. That they're going to be in that higher risk group.
Agree.
Terrific. And I think this will be the last question, and I think it's a good question. What should I tell my family to convince them all to get the vaccine if they're reluctant?
I think at the end of the day, we have to, this is our key to getting out of this pandemic. And we need about, the modeling shows that we need about 70% of the population to get vaccinated for us to be able to really get on top of the pandemic. So I think that we all need to do this for each other. And the more of us that get vaccinated, the better we're looking after each other, and the better chance and the sooner we can move forward.
Thank you.
Yeah, the only thing I would add to that is, I know that there's a lot of concern about, and there are a lot of questions about the vaccine and its safety and how quickly it came about and everything. But if there are people who have concerns about why they don't want to get vaccinated, I think every effort should be made to try and have a discussion with them, to try and allay their fears as to what is it they're worried about, rather than just to say, take my word, go get vaccinated. Let's talk about it. And so talk to their providers about it and say, and get their questions addressed so then they can go get vaccinated with more information and knowledge.
Yeah, and try to avoid as much as possible taking too much advice from things like social media where you have no idea the validity of the source. Go to the CDC website, go to the Cure HHT website, go to scientific websites where we have actual data and good valid conclusions about the safety of the vaccine.
I echo that.
Thank you. And I just can't tell you how much we appreciate you giving your time today and helping, over 200 people in real time, and probably thousands of people who hopefully will see this in the near future. I know I learned several new things today, and so I'll be able to act on them. And I would like to thank you, Dr. McWilliams, Dr. Castori, and Dr. Faughnan. We really are so grateful, and we are blessed to have you in our HHT communities as such compassionate and very intelligent physicians. So We thank you, and I thank everyone for joining us today. I wish you all well. Stay safe, wash your hands, get the vaccine. Thank you.
Thank you. It was a pleasure.
Everyone.
Our
Yep.
pleasure.
Bye now. Stay well.